Then marrow can be, of course, you need not write in the report. What you report is hypercellular, hypocellular or normocellular, that can be enough. When it is adequate cellularity is seen. Now, as far as fat and cellular components are concerned, the ratio may differ. There is a big range from 25 to 75% or more than that in neonates or children. So that fat can be seen in the fragments and that you can assess the cellularity properly. Okay. These are the thick one but normocellular, and this is hypercellular. So you can just judge the ratio of the fat to the cellularity of the fragments. This is what is seen in aplastic anemia. Mostly you are fortunate if you get such fatty fragments in aplastic anemia. Mostly you don't get anything. That is my experience. But if you get such fatty fragments, yes, they are hypocellular. Then coming to morphology. For morphology, select the best stand area, because some of the areas in any aspiration smear, whosoever be the technician who has stained it, some will be more stand or hyper stand, some will be under stand and some will be properly. So select the properly stand area and you have to count at least 500 cells. The reason behind is that in bone marrow you see cloning phenomena. So in some areas you will see the immature cells or normoblast in large number, while in other area you will see the myeloid series in large number. So to average that, minimum 500 cells should be counted. But I don't think anybody is doing that. That is a practical thing. Okay? And those cells are to be specifically counted. As far as the myeloid cell counting is concerned, many of the books or authorities are advising that you should not include the mature cells of the myeloid series. Why? Because if the cell count in the peripheral smear is more, then those cells from peripheral smear you are counted, because invariably the aspirations are mixed with blood. But most of the authorities that agree that you count the mature cells also along with that, and not only eosinophils, neutrophils and basophils, but monocytes should be counted in the myeloid series. That is the dictum given by majority of this. Of course, blast cells and all differential count is to be done. Particularly the blast cell should be properly counted if there is a case of blast cell leukemia for assessment of the treatment or follow-up. Then plasma cells and lymphocyte in suspected chronic lymphocytic leukemia and myeloma after chemotherapy. In these particularly smears, many a times I have seen necrosis. Only few books have described that, but bone marrow necrosis is a condition which has been described in few books, and in some books in few lines only. But that is also commonly seen. Not necessarily this will be associated with malignancies. You know that with malignancy, necrosis is very commonly seen. But this may be associated with ischemic conditions also. And then you have a difficulty in seeing the normal cells in those marrow. So that time you can report as a bone marrow necrosis also, because we had a case like this. So coming to this, again parasites and all leukocyte. As far as ME ratio is concerned, Now various books have given various normal ME ratio ranging from 3 to 15 is to 1. As far as 10 is to 1, 15 is to 1 is concerned, I have not seen this ratio even in leukemias. That's difficult to see, but that has been documented in standard textbook. I don't know, but my experience says that 3 to 5 is to 1 is a normal ratio what should be considered. Okay. Then of course mast cell and other macrophages, and then lipid storage diseases, of course those are macrophages which are seen, that will be seen. Osteoclasts are seen many a times, and that I have seen in the bone marrow. And non-hematopoietic cells from metastasis and other. Now coming to erythroid series, yes, you have to decide whether the maturation, mostly the normal maturation, the least number of cells are proerythroblasts, and the number of cells go on increasing as the cell mature. This is what we should see. But reversal is many a time seen, that should be noted. Okay. Then you have to decide whether these are normoblasts, megaloblasts, or micronormoblasts. Sometimes mixed picture of megalo and micro also we have seen, because dimorphic anemias in our country are quite common. The most problematic thing are these macroblasts. And these macroblasts, because in MDS, what they say is a megaloblastoid change. And these macronormoblasts, these are larger in size and sometimes can be mistaken as lymphocytes or even myeloblasts. It is very difficult, that's what I have seen. Okay? So they have to be distinguished, and yes, by describing them, you will never catch them. You have to see and learn. That is the experience. That's what I can tell you. So, these are the different cells. These are the normoblasts, which you must have, almost all of you must have seen. Megaloblastic anemia. Once upon a time, when I was doing MD, any anemia, given anemia, used to be a microcytic. Megaloblastic was a rare thing. Nowadays we are getting this change in scenario is like, as far as leukemias are concerned, less number, almost 90% of them were chronic leukemias. What I have seen now, almost 80 to 90% are acute blast cell leukemia, and the anemias almost 6 to, even we had a analysis of medical students. Almost, unfortunately, almost 30% of the girl students, which I think in this college are economically well-off students, 30% had anemia. And out of 30%, almost 50% had macrocytic picture. So that is the change in scenario occurring in this society. Now see this macronormoblasts, really difficult to differentiate from different cells and call it a macronorm. But these macronormoblasts are very commonly seen in MDS. And they are considered as megaloblastic pictures. Okay. Then these are the macronormoblasts. This is the picture of this erythropoiesis. Now this is a megaloblastoid change. Again, some of them are macronormoblasts, which is seen in the center. Then multinuclear. Now again, this multinuclear erythroid cell is again very difficult to distinguish from other giant cells or multinucleated megakaryocytes or osteoclasts. really difficult. But every time we cannot go on using special stent. Mostly the overall picture we assess or the company they keep. That may help. Okay. Now this is a pycnoid, these are the sideroblasts. Okay. And a cytoplasmic fraying that is seen here. And these are the nuclear lobulations which are seen in these normoblasts also. Now see these cells. It is very difficult to differentiate it from megakaryocyte. Now as far as hypoplasia of red cell is concerned, this is red cell aplasia. I had an opportunity to see only one case in my life, and that is one of the doctor's wife. He is my friend, junior friend, and I had an opportunity to see. What you see is marked reduction in cellularity and particularly the erythroblasts. And mature erythroblasts are rarely seen. Mostly what you see are immature erythroblasts in this. Now coming to myeloid series, again you have to see the myeloid cells. They also, if you see the number, it is very difficult to remember how many blast cells percentage wise and all, but particularly myeloblasts, promyelocytes are around 1 to 2%. And then there is a progressive increase in the number as the cells mature. The only problem is when there is a maturity arrest or agranulocytosis, when you get large number of immature cells, and that the bone marrow may be interpreted as a probably malignant condition or leukemia. That is a problem, but if you take the proper history and go into the details, or you have peripheral smears and all, that can be easily diagnosed. Okay? Because mostly you will get neutropenia, leukocytopenia in these cases.